secondary to endometriosis, because that's what a psychiatrist told me. And my third point is, in terms of the longitudinal studies for endometriosis, are there any being done starting with adolescents in terms of genetic studies or something of that nature?
For your for the third question, I don't know the answer to that. I think Dr. Nezhat is probably more informed on that. As far as the psychological aspects, given that endometriosis begins oftentimes at birth and then is fully blown by the time menarche hits, what we've noticed is that the preponderance of females, they present with psychological issues at menarche or shortly thereafter. It's not a coincidence that it hits at that time, that the self-harm behaviors, the pervasive suicidal ideation, all of those things hit at that time. So whether it's secondary or primary, it's chicken and egg. It needs to be treated in order for patients to be able to follow through on adherence with endometriosis treatment, and for them to be able to disclose and work with their doctors effectively.
Great, thank you. I have a question. Stephen, you want to say something?
I have a question.
I do have a question. I have a question for Dr. Shauba. With endometriosis and insulin resistance, have you noticed any use of metformin, GLP-1? I know it's probably a huge question that requires an hour, but please.
You give the microphone to the Shoma, come here.
Okay.
Osama, oh, good. Dr. Shaki also asked him to come here because I have a question for him.
Okay. There's definitely no data yet on this specific population and insulin sensitivity, but I think it's a little bit, you have to follow the logic of this hyperinflammatory process. And like I was saying, it's so easy to get the data on insulin sensitivity and then to monitor response to actions, even if it's purely diet. I think the pharmacologics, I think we're just still at the tip of the iceberg with the GLP-1s. One thing I do want to say is everybody's very down on it with muscle loss. We had so much muscle loss all these years because we were very locked into the branded dosages, which were extremely high. But I'm seeing so much success with using the microdoses, compounding. I feel I have very good compounding pharmacy partners. I've used hormones in a compounded way for a long time, so maybe I was a little bit more comfortable to use it. But just as a tool for this, head to toe, full body inflammatory markers, and the first. I didn't just have a specific endometriosis patient, but actually I was seeing patients with inflammatory bowel disorders. And I was a little nervous because I didn't want to disrupt constipation and things like that. But I have had at least 5 patients come back to me in microdose and they said, my GI said, I don't know what you're doing, but keep doing it because we've never seen your inflammatory markers and all of this. So I feel like there's a very easy extrapolation. And I have just patients.
Women come to us because their husband doesn't listen to them. So as well as we focus on treating patients, we have to focus on educating the family and the husbands of endometriosis patients because it's very important. I see it in my patient that the husband is not appreciating how she feels dyspareunia. He is not understanding how she suffers. So I think psychologists, you're doing a great job. Have to focus more direction to educating the husbands and the family. This is point number 1. Point number 2 about endometriosis and infertility. I'm not a laparoscopic surgeon. I feel very jealous from them when they impress you by this difficult surgery and remove the masses, blah, blah, blah. But I found some clues. Just recent publication in Fertility and Sterility, which was in my side. They said that at last we realized that most of infertility cases with endometriosis is actually related to the associated adenomyosis. So this was a very surprising article. by a distinguished team that we shouldn't ignore the adenomyosis part. We jump to cutting the ovary to remove, and we forget the real cause of infertility. Pain-wise, I agree with that. Laparoscopy is the best. But for infertility and IVF, we have to give more attention for adenomyosis and come to my playground. Thank you.
Osama is very humble about what he said. He is a master surgeon. He does open surgery, laparoscopy, but hysteroscopy is all over the world. The reason I have insisted, and we appreciate he came all the way from Egypt to share, because going back, endometriosis is the whole body disease, and the vagina and the uterus. In 1995, my brothers and I published an article that all the patients with pelvic pain at the time of laparoscopy is good to do hysteroscopy and vaginoscopy too. So we have been talking about it for 30 years, but it was criticized because it's not cost effective. That was the criticism of one of the reviewers. Ultimately, it was published. And since then, we have seen the evolution of role of hysteroscopy is not diagnostic anymore. You see, masterpieces that we do, he does adenomyosis on the vagina. So his talk was short related to the hysteroscopy, but it's one of the most important aspects. Now my question for you is, you have so much experience, and we were supposed to publish your adenomyosis in the vagina together.
Yes, yes.
Publish all of your experience. Tell people how important it is to be a master hysteroscopy. Tell them when they go and their doctor is doing laparoscopy, ask your doctor, can you please do a hysteroscopy too? And a vaginoscopy too. The patient is asleep.
The biggest problem in hysteroscopy that most surgeons think that if I am very good at laparoscopy, then hysteroscopy is easy. And then when they go down, they get lost and came with a very wrong diagnosis. In the Global Congress of Hysteroscopy in Barcelona, 2018, I did a session in front of 2,000 doctors from Europe all over the world. And I showed videos and pictures and asked them to vote. What's your diagnosis? Luis Alonso is still living, and he had the results. 67% of the answers were wrong. Okay? So between laparoscopy and hysteroscopy, there's a difference between golf and baseball. The fact that you can play well by the laparoscope, and even Arnaud Vadim was operating with me in Moscow last month, okay? And he said, oh, Osama, what you're doing is easy. He was doing difficult at endometriosis. I said, come on, jump into my room, show me how you remove a polyp. He spent half an hour. He couldn't even reach the polyp, okay? So you have to, if you want to be a hysteroscopic surgeon, you have to know that it's mentally and ergonomically totally different. We are depending on 30-degree telescope. Why 30-degree? Because in laparoscopy, if you want to see right and left, you can turn your telescope. But in hysteroscopy, you cannot see the cornea. So by zero angle, you cannot turn. So that's why it must be 30-degree. And the 30-degree is confusing because the 30-degree lens is looking up. So when you're going through the cervical canal straight, you'll be seeing only up. And you'll get confused. Oh, I'm going up, I'm afraid. So you do like this. Once you did this, you can see the internal os, and then you start to do false track. So you have to train. Hysteroscopy is different. And if laparoscopy is an option. Not every one of you should do this huge things of laparoscopic surgery like the Nezhat doing. But it's not shameful that you're not doing it. But everyone should do hysteroscopy. Should visit the cavity, get the diagnosis. And I was inspired last year by Nezhat about the AI. Now another surprise, we're working, me and Luis Alonso, to make an AI program that helps you when you're going by the hysteroscope. The computer will tell you, okay, you are inside a cavity, you have a chronic endometritis, you have an arcuate uterus, you have a septum. So it helps you in the diagnosis. So I believe that each and everyone should start playing with this simple tool and do great things for the women. And thank you again, Sina, for inviting me. 16-hour flights, worth really the pleasure being with you. Thank you.
Thank you, everybody. We're running really behind for the next session, so I think we'll have to wrap it up and start the next one. Thank you so much. why don't we start? We're kind of running behind anyway. So next session is debate, ultrasound versus MRI. And we have Dr. Leena Potter, did I say it right?
Yes, Dr. Potter, she's one of our outstanding women's experts in radiology, and is going to do an overview of ultrasound versus MRI for endometriosis. And then we're going to open it up into a debate of why each person prefers one over the other.
Thank you. Good morning. And thank you for the society. And thank you for my OBGYN colleagues from UCSF who have taught me a lot and keep me current as well as enthusiastic about women's imaging. I'm a body imager, and my special interest is maternal fetal imaging. So I actually see, I see women when they have the pain from endometriosis or screening, or we're working them up for infertility, and I see them when they get pregnant and also after the pregnancy. So, and I'm going to give you somewhat of a radiologist's perspective. And first, what I want to say is that I would prefer to say ultrasound and MRI, not ultrasound versus MRI. And we can have the debate later and see what everybody else thinks. But from an imager's perspective, I use multimodality for a lot of GYN and any other type of imaging. But as far as endometriosis, what we use is ultrasound for screening, and then MRI for preoperative or pre-treatment planning. And then also we go back to ultrasound in a certain clinical scenarios, if it's available, for preoperative and intraoperative detailed planning. So there's been a lot of talk about the delay of diagnosis of endometriosis. And then despite the advancements in the recent literature and then overall development, we have shortened the timeline for the diagnosis. But if you look at this data around the world, it may not be 10 years, but it's still kind of long. So then it is thought to be perhaps primarily driven by physicians, and maybe more focus has to be in the areas of primary care and where the patients originally present, not necessarily with their gynecologist. But I'm going to focus on how the radiologists or imagers can sort of shorten the timeline. So looking a little bit about the popularity or the awareness of endometriosis, it has really increased. If you put in endometriosis on the PubMed, and you can see that it really spikes around 2010, and then especially in the past 15 years. So really there's been a lot of interest. So that brought us together within the Society of Radiologists in Ultrasound in 2024. And we wanted to see how we can advance the detection. And so this was a panel. We decided to a consensus statement how to quicker diagnose endometriosis. So there was about 16 multidisciplinary experts, and we came up with the diagnosis that recommendation was that augmented ultrasound was improve the detection in appropriate patient population. And it needs to be validated, but there have been some validation studies out there already, and we've done that in our institution. But what is what does the consensus say? What did we come up with? So basically, we all know that routine pelvic ultrasound has a lack of optimized detection. It takes about 30 or 45 minutes, but the consensus recommended it will have some augmentation to the ultrasound, and it would only do extra 2 to 5 minutes. And what we would do is particular maneuvers in the posterior compartment where we know that endometriosis is most common, and it's more of a dynamic scan. And also we are guided by the patient's clinical symptoms. And we are looking for the direct and indirect observations of endometriosis. And so we would apply this in a screening populations. And essentially, if we look at this is our everyday, almost every patient in our in our lab will have some of those symptoms. So a lot of women, would it be premenopausal, peri, or even adolescents, they would certainly the majority of patients will fall into this category. So we're looking for some of the direct observations, which would be the direct evidence of the endometriotic tissue outside of the uterus, and looking at the implants and then the reaction of the body to the implants. We are also screening for indirect observations and signs that suggest that there is endometriosis, but we may not see necessarily the plaques or implants, but there are secondary signs such as adhesions or uterus is fixed, retroflexed in position. So we divide it into these three categories: the direct observations, indirect observations, and then endometriosis associated observations. And then decided to have a sort of a scoring classification categories. And like with everything, the world is not perfect. So sometimes the exam may be incomplete, the patient may not tolerate the examination. It could be normal, there could be some equivocal observations, and there could be clear signs that we are highly suspicious that there is endometriosis. So here are some of the examples, let's say in the category A, when we have direct endometriosis observations, implants in the uterine serosa, and on the ultrasound, this is when we'll be forming the sliding sign. We're trying to separate to see, is the uterus moving separately from the posterior compartment from the bowel? But here you can see how it's kind of dragging the tissues along. And also you can see that there is this plaque, a lot of implants in the posterior aspect. This patient also has adenomyosis in the posterior wall of the uterus. And it was closely correlated to the MRI, where you could see these glandular deposits along the torus uterine, the posterior uterine serosa, and the uterus is also somewhat of a fixed position. Here's an example of a more subtle indirect observation for category B, and this uterus, even on a transabdominal examination, you can see that the uterus is retroflexed, quite retroflexed, and sometimes, uterus is mobile, we see them transabdominally retroflexed, and then we do the endovaginal scan, and it changes its position, but if it is truly fixed and adherent at the torus uterine, then, or in the posterior compartment due to the adhesions, then it does not move. And in this case, you could see this as well on the cine, and that was confirmed just as a correlation case here to show that there is plaque along the torus uterinus and this posterior aspect of the uterine serosa. And again, one of the most important signs was the sliding sign to screen in those patients to see that the uterus is moving nicely separately from the posterior compartment. And if it does move separately, that means that we didn't see any suggestion or signs for deep implantative endometriosis. But again, this sign, it took us a while to teach our sonographers and also our clinicians to do this sign. It's a little bit of practice. If the uterus is anteverted, we would ideally put the probe into the posterior fornix. And similarly, if it's retroflexed, it's best if you put the probe into the posterior fornix rather than anterior. And then gently apply pressure transabdominally to see the compartments sliding or not sliding separately. But not only that the sliding sign helped us to identify more patients, but also really raised the awareness amongst the clinicians as well as the sonographers to look there. Because really, you only diagnose what you know and you only see what you're looking for something. So we also recommended that, this is sort of what stemmed from this consensus document, that what are the recommendations when we see those signs? So of course, if it's technically incomplete, if the patient is symptomatic, then of course, additional imaging would be recommended. And if it's normal, it doesn't mean that the patient does definitely not have endometriosis, as we know. And so perhaps another imaging such as MRI would be indicated, depending on the clinical symptoms, of course. And then if you have category B observations, then based on symptoms, consider referral to endometriosis specialist. And if we do a lot of the, if it's positive and we see several findings, so based on symptoms, again, we would recommend considering to the endometriosis specialist and advanced endometriosis imaging, such as MRI or targeted ultrasound. So recently, as in fact this year, it's sort of being written up right now. We had 2 academic centers. We looked retrospectively about almost 900 patients, and we reviewed the studies. All of those patients had the sliding sign, and we have done the modified protocol, and we found that 30% of patients that were positive, who had the the APU had findings that were positive or equivocal for endometriosis. And those who basically were category 3, 76% of them were confirmed to have endometriosis in the subsequent MRI or surgery. So a little bit more about ultrasound and what we learned when we were teaching our sonographers and actually learning the techniques ourselves is that ultrasound is really, really good in its sensitivity and specificity to looking at the bowel involvement of endometriosis. So because we see exquisite detail of the muscularis propria and the wall layers of the bowel. And I'm going to show you here. So this is a normal hypoechoic muscularis propria. And on the other cases, you can see this is a thickened muscularis propria in 2 of those cases, and which is indicative of muscularis involvement. And you could really see that the mushroom cap sign, what we talk about on an MRI, beautifully on the ultrasound. And I don't have the lesions in the center of the screen on those two videos there, is because we saw this lesion retrospectively. It was not picked up because we were not looking. So again, wanting to emphasize, we really only diagnosed what we're looking for, and we were aware of what we should be looking for. And just showing some correlation here, this is a patient who had sort of a fixed pelvis, kissing ovaries bilaterally. You can see endometriomas correlating to the MRI, and also the extensive endometriosis involving the posterior aspect of the uterus, more the outside in, not the adenomyosis from inside out from the junctional zone and the endometrium, but more of the outside in process correlating to the MRI as well. So basically, ultrasound and MR, they are comparable in their performance, but again, in expert settings. So here you can see on an MRI, the glandular deposits on T1, the beautiful mushroom cap sign visualized well on the ultrasound, as well as on the T2 sequences and MRI. So here's a couple of examples for the more targeted preoperative, intraoperative planning ultrasounds from my colleague Scott Young from Scottsdale Mayo Clinic. And this was a patient who was scanned in the OR because it was only one large lesion was identified on preoperatively, but during the surgery, 2 other smaller lesions were identified, and they were actually not visible only per palpation when it was guided by the ultrasound. And you can see that we're also very good with the targeted and dedicated ultrasound to show the exact length and size of the lesion, which really correlates to the gross specimen here as well. So about screening and targeted mapping, ultrasound is really good. The strength is it is a first line modality because most of these patients are presented to the ultrasound lab first for, they may be suspicion for endometriosis, maybe not, but if they have certain kind of clinical history, we know what to look for. It's also widely available, it's cost effective, and it's important that we can do the dynamic evaluation and the sliding signs. We can also be guided by the patient's clinical symptoms. So it's really good for looking at the different phenotypes such as ovarian endometriomas, evaluating the posterior compartment. You can have exquisite detail looking at the bowel, and you can really see the thickened ligaments. You can evaluate for endometriosis, and it's great for targeted bowel mapping as needed. Potential limitations, it is because it's operator dependent, and it also, especially when we're doing this really targeted exam or trying to map, it is really time consuming. And it's considered not as good for anterior compartment. However, we do get quite nice images evaluating for the C-section scar and the bladder wall and so forth. And also higher pelvic disease, it's difficult to detect small bowel involvement or appendix or other areas, and other extra pelvic disease, and also a nerve involvement, which we all are aware now, we're seeing it more and more often. But it really is a best initial test in expert hands. So what about MRI? MRI itself, it also has its strength. It's great for preoperative pre-treatment planning, and it's helpful in multi-compartment involvement. It's excellent to moderate to severe disease, and it's also good for screening in the setting of potential malignant degeneration. It is less operator dependent as far as if you follow the protocols. However, it is interpreter dependent. So really the radiologists who read those MRIs need to know what they are looking for. And as all the modalities, we as imagers are not as great as looking at or identifying the superficial disease and also evaluating the adhesions. And, it's not a dynamic exam. There is no endometriosis. And just a little bit of background here, in order to interpret those studies so they would be valuable and impactful, all of us as radiologists need to speak the same language. We need to know what we're looking for. So there's been great efforts done by the Society of Abdominal Radiology. There's an endometriosis disease focus panel, and we have worked at the protocols, how to do those studies, how to perform them, and what and how to report. And that's obviously also been in very close association with our clinical colleagues to know. We need to know what you want us to tell you and what best prepares the patient for treatment. And so the most recent ACOG guidelines, just wanted to illustrate it here as well, as you more than anybody are quite aware of this, that again, ACOG recommends that ultrasound would be the initial imaging study and MRI if there is a further disease characterization necessary. And as I already stated earlier, that negative imaging does not really exclude the disease. And really, if you're looking at experts in many of the areas, the ultrasound and MR, they do perform quite well. And it really depends, what is available and what kind of experts do you have available. And it's important that if you're screening those patients, it is better than not to have the routine ultrasound, but have these, add those steps, what we were illustrated here. It only adds 3 to 5 minutes to the ultrasound, and we get so much more information. And having to do that, again, wanted to emphasize how all of our sonographers, because in the United States, most of the studies are performed by sonographers, they have really learned to look there, because previously we only picked up the posterior compartment disease on those images where the sonographers presented us the sagittal views of the uterus, looking at the lining and so forth. And we're like, what's that in the back? And then now they're really focusing, using the focal zones in the posterior compartment to see it better. So lastly, what do we do at UCSF? So we use ultrasound screening. We are not using strictly the guidelines, the reporting, but we are using all the maneuvers. And if we see findings, we usually recommend MRI for multi-compartment evaluation for the disease and for the patient's counseling and treatment planning. And then we are learning with to improve our expertise and how to kind of apply the targeted ultrasound for preoperative or intraoperative planning. So just wanted to leave here one of the patients we had with Dr. Lager together, who had an MRI and had a lot of disease, but the patient was very hesitant to have surgery. So it was part of the evaluation. We decided that maybe we'll do a targeted ultrasound to confirm and sort of show, is it truly present what we saw on an MRI? And then can we find something else? And we actually found incidental ileal lesion, and we were able to, really accurately map where all the disease was in the posterior compartment, and also several bowel lesions. And so the patient was more comforted, and maybe you can comment how that impacted the evaluation.
Yeah, oh, perfect. I think that combining both of them at times can be super helpful for preoperative counseling. And in this patient, for example, once she realized the extent of endometriosis, she continued with medical management and is doing really well at this time, but we continue to follow it. And I think that one of the important parts of this particular case is that the ileal lesions were not initially picked up on the MR, but then once we had the additional targeted ultrasound, we were able to see them.
And then it's really not commented a whole lot in the literature, but in our experience, we do have difficult times evaluating the small bowel, especially because a lot of peristalsis, we use antiperistaltic agents, but it's not really perfect. There's a lot of motion. In an ideal world, you'd like to have all the patients undergo bowel prep, use vaginal or rectal gel, but because it's not really always possible, and we do that more in a targeted population. So we are limited as looking at the bowel lesions. So what I think, just wanted to stop here and open it up for discussion, is that I think most important is communicate that the radiologists or imagers, that we communicate with the clinical teams, know what is needed, and help the multidisciplinary care of those patients. Thank you.
Great, thank you.
So since there's to be a debate, and probably I will be a little bit much more polemic, and I think that also a negative laparoscopy is not the same that it is can be endometriosis true, and therefore it is important that you can see my slides. So I want to convince you that ultrasound in gynecological hands is much more better than MRI and ultrasound in radiological hands. So just to have a debate. And you heard that we can have our first line, and I think all of you have an ultrasound machine in the office. But who of you ask if you are a little bit suspicious? Ask for another magnetic resonance. So you believe in your ultrasound, and me too. And the first is that I want to stress that the sliding sign is not always good, because here we have the deep endometriosis and the sliding sign is negative. Here we have also deep endometriosis, sliding sign is positive, so we have to look to the lesions. Don't look only to additions, look to the lesions. And with ultrasound, we can see a lot of lesions, which are very good seen, and you heard it before. So, and the question is, but with ultrasound, you cannot see nerves, you cannot see superficial endometriosis, so therefore we have to go to laparoscopy. That's not true, because we can see the parametrium very well, and we can describe it, and we do this paper, and then we understand that we can see also the lateral wall. So this is not only the ovaries, here's the ischium, here's the obturatory muscle, here is the elevatory anus, then we can see the piriform muscles, we can see the sacral plexus. So when we can see the lateral wall, we can also see where the nerves are and where they are affected. And finally, we can also suspect superficial endometriosis with these irregularities of the peritoneum. You can see here you have a little bit fluid inside, and you can see these irregularities, and these spots are very typical for superficial endometriosis. So I think that we have to distinguish diagnosis from pre-surgical workup, and for ultrasound diagnosis and management is very important that in gynecological hand, you can make the diagnosis, you can make the management, you can follow the symptoms with a pain mapping system during your scan, and it gives us also the opportunity to go to infertility, to see the tubal patency and also the ovarian reserve. But then you ask me, why will you have so much delay? If you are so good in ultrasound, the gynecologist can do this. Why? And I said, I think that sometimes we need a second medical options. That means sometimes when we have suspicions of the patients had pain, a second expert ultrasound or opinions is very important. And therefore we are pushing a lot for endometric center where you can send the patients for a second opinions. And finally, I want to stress, because I heard about adolescents, we do our early diagnosis from adolescents by ultrasound. And we saw that in adolescents that comes for ultrasound or for other opinions, we can detect endometriosis. And now we are looking also in different ages with ultrasound, non-invasive. We don't need to go to surgery to see that in adolescents we have a lot of ultrasound positive on the uterosacral ligaments. So remember that ultrasound gives you also the possibility to go to follow-up. What about pre-surgical? Every time we said, magnetic resonance is much more better than we have to go to surgery. There's much more you can see where the diagnosis is. So when you see these papers, this is again a meta-analysis of different papers. You see that transvaginal sonography sensitivity is very low, specificity for magnetic resonance is very high. But look to the papers. They are 10 years ago, these papers. That means that you cannot do a meta-analysis on papers that before don't see anything that we are seeing now by ultrasound. And if the ultrasound is done by expert, you see that the deep endometriosis had a high accuracy and high sensitivity and specificity. So it is clear what it was said before, that when we compare these two methods, we can see that ultrasound is much more better for ovaries and for uterosacral ligaments because you have it on the tip of your probe or for the rectum. And magnetic resonance is a little bit more better for ureter or for pelvic side wall. So the combination, and we are not shared this ultrasound before, but the combination is probably for the preoperative workup very important. Despite this, despite we have the combination, until now we have an overlook of the lateral pelvic side wall, which is important because they are the most important comorbidities, and therefore also the combination and also the work with the surgeons is very important, not only with the ultrasound or gynecological people that do imaging. And this is why I think that sometimes surgeons has to do their imaging themselves. Then that they can visit, they can see the lesions, and having the probe in your hand and then go to surgery, they are much more better because they know also better anatomy than imaging people. So to be very clear, it is that magnetic resonance had the same similar detection rate, but it's better, ultrasound is better for rectum, for ovary, and for upper abdomen. But what is very different is the dynamicity for ultrasound, and also the problem is that these two imaging don't speak the same languages. Unfortunately, we have different schemes, and so we cannot often compare, because often the schemes of MRI are different from these of TBS, and the ultrasound people and probably radiologists should be seen together. And the other problem is that these classifications missed completely the lateral part of the pelvis, so parametrium and lateral wall. So it is difficult also for speaking for intra surgeon that we cannot have the same languages. So these are the 10 reasons why I use ultrasound also in preoperative workup, because it's cheaper, more easily, it's general. The accuracy is very similar to MRI. It's better on the rectum. It's better on the uterosacral ligaments. It has a dynamicity, so you can also see the additions. It's non-invasive, especially for adenomyosis, which you have not to miss. Has also a visual mapping pain. So when I touch the uterosacral ligament, I see the thickening, and I push, and the patient jumped on the bed. I know that this is endometriosis. And finally, we can do also ultrasound during surgery, and finally, it can permit us a follow-up after surgery, prior to surgery, or without surgery. Thank you for your attention.
Thank you so much for that part of the presentation. We were planning to open this up into more of a debate. One of our speakers had to go to the airport, so we lost one of our speakers. But I will say that from my perspective, at UCSF, we have an outstanding interdisciplinary group. And so we review all of our MRI imaging together, along with reproductive endocrinologists and the rest of the team. And it's very helpful for pre-surgical planning to have the MRI imaging, in part because our colorectal surgeons are much more comfortable for surgical planning to look at the MRI, to do consultations, determine if they need a colonoscopy prior to surgery. When we're working with our urologists as well, we'll often look at our MRI imaging together. And then with thoracic surgery, we will sometimes also add a CT for our imaging purposes. So from our perspective, I think MRI has been superior for anyone that we're doing surgical planning or for pre-operative planning and evaluation.
Yeah, but with MRI, you don't evaluate additions. You don't evaluate exactly the rectum, which is much more better by ultrasound. And I often see that you miss rectal nodes, especially in the lower part, and in the sigma too. So it is very. We ask for magnetic resonance very rarely preoperatively, and our surgeons look to the ultrasound with us, so they have also the dynamicity. And I think that in gynecological hands, sometimes it is also that you add also the symptoms, you add the problems of the patients, which sometimes the radiologist doesn't do. And the problem is that I think that you need also in radiologists experts in the endometriosis disease. And because we have negative ultrasound, but we have also negative magnetic resonance. And I think this is the daily problems that we have.
And I think one of our duties as clinicians is to give them a very good history before the ultrasounds, because I think that if they know what they're looking for, then they can give us a little bit more information. So I think it's important to add what the symptoms are, to have their expertise to really look at an eye of what we're interested in.
So yeah, I just wanted to add as well. So it is really important to have, like a lot has been said, like having the experts, because that kind of applies in many other areas of imaging for sure, is that, you know, there are people who are experts in one modality or one entity, but many of the times it's like you kind of have to cross the boundaries and you have to, you know, what does this one imaging modality give you and what does the other? So they're kind of, I would like to think of them as more complementary, but obviously you have to have the expertise in the background to pull it together as an imager.
So we can say that if you go to preoperatively, so to pre-surgical, we can use both technique, better both together or both. But what about diagnosis and diagnosis delay? Because this is the great problem that we have, because if you have a suspicious of, she had pain, and I think it's suspicious for adenomyosis, it's a young patient. Should I send her to magnetic resonance, or should I, of course, an expert ultrasound, or both?
But I think a lot of it is, as I said, is the awareness, because I have learned that, you know, ever since the Society of Radiologists ultrasound consensus, when we instituted the sliding sign, and it's not about the sliding sign necessarily, it's more that training your eyes to look behind in the posterior cul-de-sac, because our sonographers now that they know what they're looking for, they, you know, call us up and say, I think I found something, and then, you know, it may be positive or not, but at least it's much more, we are aware, what are we looking for? So that's important in the screeners. And we may see those patients before they come to the gynecologist, because a lot of our pelvic ultrasounds are ordered by primary care. And this, as you see, they qualify for the screening based on their symptoms. And you know, I think we will make a big impact as imagers if we do think about it. Well, these are the symptoms. Did I look in the right places? Did I do the right study?
So you don't think that gynecologists that use ultrasound daily should not a little bit more teach to have this look also, not only sonographer, but probably they need to the young, especially the young generation, to understand how to deal with the ultrasound probe, because it is very important, not only for endometriosis, but remember, in the emergency room.
Yeah, absolutely, yeah. So really the expertise, and I mean, it depends on what is the practice like. Like I know in many other countries, like the physicians will, or gynecologists do the ultrasound, and it really depends on the practice pattern.
Hi there. Yeah. Jennifer Dietrich, Baylor College of Medicine and Texas Children's Hospital. So you kind of got into what I was going to ask toward the end. But certainly in a children's hospital setting, the gynecologists are not doing the ultrasounds. It is the pediatric radiologists, and they will simply not do a transvaginal ultrasound in anybody who is under 18 and not sexually active. So it is a transabdominal approach. Therefore, MRI sort of helps guide and augment our surgical planning. But certainly I can see they occasionally will use a transrectal probe. But I can think of nobody who would be comfortable in assessing for endometriotic lesions outside of maybe possibly it's an endometrioma versus a hemorrhagic cyst, but they would hedge a little bit perhaps. So how do you build capacity in the pediatric radiology provider groups to perhaps look at this if we were to ask them to take that transrectal look in order to really scan the pelvis, look in the cul-de-sac, look at the uterosacrals, look at the sidewalls, because I don't think they have that comfort level in this patient population, and this is the patient population where it starts and where we need to make an impact.
Yeah, I'm glad you brought it up because actually I work very closely at UCSF with our pediatric colleagues, and even that was even before endometriosis, because the same kind of ovarian torsion, other ovarian lesions, it's not really within the realms of a pediatric radiologist as much, because we see day in and day out all the time and we become experts, but it very rarely happens in the pediatric population. So there's always some discomfort in that area. So we've collaborated with them, and actually now we started we pulled the pediatric radiologist into our endometriosis center, and us as adult radiologists review all their cases with them. And we help them kind of to uptrain, to recognize the signs in the adolescents. And we haven't, it's certainly something to consider to do the rectal, but we do a lot of MRIs in those patients right now, but also do a very good screening transabdominal, because you can see a lot transabdominally.
We are publishing more than 400 adolescents. So when we are speaking about endometriosis, we are speaking post-menarchal problems, okay? So, and I don't know why in Italy, on 400 adolescents, I have only 20% sexually not active. So we are patient of 14, 16, these are the age that we see. Generally, they come sometimes for dysmenorrhea, but also for dyspareunia, vulvodynia. So the problems is not at 12 years, but much more, a little bit higher, 15, 16, okay? And they are not always, but if they are sexually inactive and they have pain, and you have to understand that you can speak with the patients, speak with the mother of the patients, and the rectal scan is not so worsened to see the uterosacral ligaments. This is the first, and I saw the video of Professor Nezhat. This is the first step of the endometriosis. It's not the ovary. It is the uterosacral ligament. If you push on this, it's very important. So we look very carefully at this, and then you need an endocavitary probe for this. But when you do the diagnosis, it's so important that you then treat the patient, and it is important to do the diagnosis. And this transrectal ultrasound gives you a lot of information.
And
I have
also
a question for you.
transperineal.
I'm sorry.
Yeah, let's say the transperineal, you could also see the posterior compartment quite well in those who are not sexually active.
So, very good question. I have it for both of you. But when you want to do transrectal ultrasound, or even vaginal, do you tell the patients to do at least an enema or something before they come?
Yes, I ask for an enema. If they come for endometriosis or pelvic pain, I have this indication, I ask to empty the rectum, not really an enema, but to be free. remember that we see endometriosis is on the anterior rectal wall. So it is not the fecal give us not a shadowing on this anterior rectal wall by ultrasound.
Yeah, the reason I ask because I do see a lot of young people who are not sexually active, and when they want to make the schedule with their mother, and I don't know if they are sexually active or I anticipate they'd like to do transrectal, I tell them to give an enema. If they are resistant to do an enema, definitely I would not offer the transrectal. I don't even offer rectal exam. But if they do the enema, when they come and we are not able to do, especially if they are obese, abdominal ultrasound is not going to show anything. To do the vaginal or rectal ultrasound, so I tell them this is just like the enema. And I ask the patient, can you insert it yourself? We call it patient-assisted rectal ultrasound. So I agree with Professor Exacoustos that rectal ultrasound could be very informative because we mix it with the examination and we point at the area. A technician cannot do that, but because I know the anatomy, I can point it there. So I thought I'd just share this with you.
Yeah, when we do the targeted exams, we also ask the patient to have a bowel prep and kind of a mild bowel prep, like 2 enemas. And so then we do, and we have, certainly when we need to do the transrectal, we always have the physician do the transrectal with the sonographer,
So you point out a very important things that surgeons do know very well the anatomy. And I think that in this case, when they can use also the probe, there are a lot of advantages because for sure they know where to find the ureter. Sometimes when I teach, they look for the ureter like this, and I know that the ureter has to go laterally and a little bit on the side, and this is for surgeons obviously, but for ultrasound people or radiologists or is not so obvious. So the teaching to surgeons to have this type of ultrasound in their hand is for me a very good, important thing.
Yeah, and one other point I wanted to mention was that because we see a lot of those patients, and especially if the patients have been pregnant and had a C-section, so the uterus is kind of pulled out of the pelvis, and if you have a lot of disease, even though ultrasound images, when you get close to the lesion in the bowel, the images are exquisite. But if the entire uterus is pulled out of the pelvis, it's really hard to even get close to the process. So in those instances as well, like you kind of have to use the combination. You clear the lower rectum and the sigmoid, and then there could be a lot of disease higher up what you would have to evaluate with the other modality.
Wonderful. Thank you very much. This has been a wonderful. So the winner of the debate is the patient. That in the right hand, they could get the right diagnosis. And we are going to go to the next session, or I think we are running late, so. You already are on autopilot, getting your coffee break if you want, but for the sake of time, we'll stay on the schedule. The next session is interesting. If you want to stand up and stretch, it's fine, but we'll see what happens to the next. The good thing is one of the speakers from Greece got stuck, couldn't come, so we have 15 minutes extra. I told them to come back. I told them don't go. Thank you.
Look at the You're the first one. Because the first one was okay. Here is great. Good, it's perfect. It's perfect. Here is perfect.
Hello.
Yeah, this is supposed to be the second one, but the first speaker, Dr. Hilaris, beautiful picture.
I mean, we can start now.
Yeah. Yeah. Like he said, I can start. All right. Good morning, everyone. I would like to welcome you to our session number 9. The session is entitled Oncology, Risk, and Endometriosis. My name is Oleg Taratula. I am a professor and associate dean for research from Oregon State University College of Pharmacy. And today I have a great pleasure and honor to moderate this session. Today we're going to have 3 great speakers, so I thank you for staying with us, and hopefully you're going to enjoy this session and learn something new. I would like to introduce health system, and she's going to tell us today about her perspective on clear cell ovarian cancer and endometriosis.
Thank you so much, Oleg, for introduction. I would presentation from our patient that's relevant to our session. Is that now scheduled or in the afternoon?
Yeah, we got the video. Oh, okay. Yes. Sorry about that. So yeah, we will start with the.
Hi everyone. It's an honor to share my story with you. Thank you to Dr. Tanja Pejovic for the opportunity, and thank you for listening and for all that you do. My name is Julie Hackett. I'm 53 years old. And in March of 2020, I was diagnosed with endometrioid type carcinoma. That was the first I heard that I had endometriosis. Today, I'm thriving, I'm doing really well, and I do everything I can to help others. And I hope today will help you help others. All right, so to tell you a little bit about myself, I was born in Egypt to an Egyptian dad, and started my period when I was 12, and when I was 21, here in the States, during my undergraduate education, I developed a ruptured ovarian cyst when I was 21. 3 months later, I had bilateral cyst adenomas removed and immediately got on birth control pills, and that continued into my mid-30s. During that decade or so of my life, I continued to struggle a bit with ovarian cysts. I was not able to have kids. I had developed some fibroids, and my weight continued to be an issue. In my mid-30s, I developed a blood clot in the portal vein of my liver, had a liver resection to remove that, and of course, stopped taking birth control pills at the age of 35. I was doing a lot of airplane travel, and my lifestyle likely contributed to some of that, they think, in combination with some of the medical conditions that I had. By my mid-40s, I had continued to see my weight go up, continued to struggle with fibroids, continued to have a number of CT scans, ultrasounds to monitor everything, pelvic exams, nuclear tests, all the things. And by December of 2019, something was very different. I was having pain in my lower abdominal quadrant that was similar to an ovarian cyst, but different, and also my urination patterns had changed. I contacted my gynecologist, and she immediately got me in for a CT scan, and by March of 2020, I had a hysterectomy, I had a tumor removed from my lower abdomen, and I was diagnosed with endometrioid type carcinoma. Dr. Pejovic put me on a treatment of 5 Taxol and carboplatin infusions, and we stopped at 5 and replaced or finished my treatment with 2 rounds of Keytruda based on the molecular profile of my tumor. And I finished treatment and went into remission effectively September of 2020. As you might imagine, treatment for cancer is not easy, and treatment for cancer during the early stages of the COVID-19 pandemic was not easy. It was not easy for providers, and it certainly was not easy for me as a patient. From challenges with communicating with my doctors and care team in person, to an inability to have somebody come to the infusion center with me to carry ice so that I don't have to, suffer from neuropathy, as a result of using Taxol, to a number of other things, inability to have access to just basic care during that time. Basically, what happened from September of 2020 through about September of 22, my weight ballooned to about 267 pounds. I decided to start working on losing weight again, and did so a little bit by myself. And then August of 2024, I convinced my primary care physician to let me take a GLP-1. Today, I'm 115 pounds lighter, and I am convinced from where I sit, based on the way I feel, and I will tell you, I feel terrific, I feel healthy, I feel probably healthier than I ever have, and I feel in control of my life, and I feel like my life has changed for the better. And I'm convinced today that treating the disease of obesity early on in my life, had that been possible, in combination with treatment that recognized that I had endometriosis, may have led to a different outcome for me today. Perhaps I would have children, perhaps I may not have developed cancer, perhaps all of those things may have happened. But nonetheless, that is where I'm at. My vision and my hope for the future, especially given the focus of this conference, is that you will use all of the tools, all the technology tools available to you with AI and other resources, but also work across disciplines, identifying the patterns to treat proactively patients, and to hopefully ensure that no woman or no person struggles as I have with some of the conditions that I've had. Thank you so much for listening.
Thank you, Julie, for sharing this story with us. And we're going back to our first speaker, Dr. Tanja Pejovic, and as I already mentioned, Dr. Pejovic is going to talk about clear cell ovarian cancer and endometriosis.
Okay. Thank you, the organizers. Thank you, Dr. Nezhat, for having me here today, giving this short presentation and summary on molecular changes in endometriosis and clear cell carcinoma. Just trying, okay, good. Who is going to change the slides, me or somebody else? It seems me. Okay, so I think everybody in this audience know that really it is important and relevant issue talking about cancer in patients with endometriosis. Ovarian cancer comes in several histotypes, and it is well known the clear cell carcinoma is the most frequent histological type associated with endometriosis, followed by endometrioid and some other types. And really, clear cell carcinoma is so specific. It belongs to the group of rare cancers. What's the definition of rare cancer is that there is less than 15 cases per 100,000 of people. And the incidence of clear cell carcinoma is about 1 to 2 per 100,000 people. So how that cancer, how is it specific? How is it special that it differs from much more frequent high-grade serous carcinoma? So you have on the left characteristics of clear cell carcinoma. So and on the right, high-grade serous. High-grade serous is really disease of DNA repair and genomic instability. It presents in advanced stages. Actually, I think that most of them presents in stages 3 and 4 without chance to detect it much earlier by imaging or other modalities. It is really very unstable cancer, as opposed to, and it appears it's diagnosed in postmenopausal years. Clear cell carcinoma is disease of younger women. It usually presents in stage 1, which is good, but it is high-grade cancer, so it has aggressive course even at stage 1. It may have. It has few genetic changes. It is not basically genomically unstable. We can follow it progressively. difficult to see, I have to get reminded. So we think that there is a clear progression from benign endometriosis to atypical endometriosis, some borderline changes, and eventually invasive carcinoma. And these are accompanied by molecular changes. Hallmark of atypical endometriosis and clear cell carcinoma is mutation in ARID1A leading to the loss of the protein, PIK3CA mutations, PTEN mutations, and rarely KRAS mutations and genomic instability. But the important thing here is that we can trace ARID1A mutation and loss already before cancer develops. If you look at this expression map or a heat map, you will see that ARID1 on the left side, it is present in benign endometriosis, and it is really lost in atypical endometriosis, and it's lost in clear cell carcinoma. Similarly, PTEN that is lost in clear cell carcinoma, it goes to successive loss, and then red colors shows you how the expression of the proteins, some other proteins, increases, such as PIK3, from benign endometriosis to atypical to cancer. This is now just tabulated differently, the same information, going from endometrioma and endometriosis, which presents chronic inflammation, niche of chronic inflammation, increased oxidative stress, as a really fertile ground for genetic alteration to kick in and start malignant transformation leading to invasive carcinoma. And again, as I said, ARID1 successively gets lost from benign atypical to cancer. The consequences of ARID1 loss are very significant on genomic level. First, although I said that clear cell carcinoma is largely stable, genomically stable disease, loss of ARID1 leads to impaired DNA repair. Also, it changes epigenetic regulation in endometriotic and clear cell tissue. And if we start with endometriosis, the tissue is already epigenetically changed. Also important, immune signaling is affected by ARID1A loss because the number of neoantigens increases, and therefore some cases of clear cell carcinoma may be sensitive to immune therapy, to ion inhibitors. This is, I'm going to switch a little bit to our work, and that is, we have used the tissue microarray of 180 cases of ovarian cancer. On that tissue microarray, there were only 10 cases of clear cell carcinoma, 10 cases of endometrioid carcinoma, and 1 case mixed clear cell and endometrioid. What we did is basically we stained 2 consecutive sections of the TMA. In the first row, you will see epithelial markers, staining with epithelial markers, and in the second row, there are stainings for stromal and immune markers. Once the staining was done, the intensities were checked by computational programs, and we have basically tried to cluster cells based on similar markers, and then do additional level of clustering where we actually told the program which clusters we want to focus on. Cancer markers, immune markers, stromal markers, and endothelial markers. So you will see here on the graph on the right side, each column represents a tumor, so from cases 1 to 10. And you will see there is green color, expressed in many cases. These are cancer markers. But there is great heterogeneity in cases 4 and 7. There is strong impression of stromal markers. And then, not so surprisingly, but strikingly, there there are blue markers. These are immune markers. They're dispersed across the cases, but they're really not abundant. This is a minority. This is just a platform that shows you that we had all clinical information or clinical data were very well annotated in all of these clear cell samples. These are samples, 10 of them, as I said, on the left, and then endometrial are on the right side, and then the pink one is mixed sample. So we have BRCA status, stage, response, everybody got chemotherapy, response to chemotherapy, early relapse, as well as 5-year survival. The survival graphs on the bottom are not really relevant so much to this talk. They show differences. There was no significant difference in survival between clear cell and endometrial group. This is also showing you expressions of proteins across these 10 samples. What is striking here, not to go through all the markers, but we have focused on genetic markers, and you can see what is in red is highly expressed, what is blue, the expression is low, and you have seen some foci of red where some pathways are activated. Not surprisingly, AK2, PA3CA, also HER2, which I addressed last year. They're all highly expressed. There is no really expression of hormonal ER and PR receptors here. And so basically this slide shows us activated pathways that may have therapeutic relevance. But so far we talked about genetics and how we talked about cancer markers and cancer genes, but clear cell carcinoma is also known for its microsuppressive environment, to the immunosuppressive environment. So far we did not address that. So on the slide 2, as I showed initially, we looked at all immune markers. In this case, on the left bars, these are absolute numbers of cells per each case. On the right side, these are the same numbers, but they are presented as ratio, so they're more normalized. And again, you will see here, for instance, green color shows CD8 cells. There are CD8 cells that are cytotoxic across the samples, but again, there is a great variety. There is also not so unexpected, but we didn't so far pay attention to CD20 cells. But there is also great expression of macrophage 2, which are immunosuppressive, and Tregs as well. So all in all, it seems that expression of immune markers, or the abundance of suppressive immune markers, is variable, and yet they're present. That is now we looked at protein expression of these markers on this slide, and leading to the similar conclusion. First, stroma is actually the stromal markers, and that is in the right lower quadrant. You will see SMA and PDFR. These are really highly expressed. So stroma in clear cell carcinoma is very tumor reactive. And that is under background of immunosuppressive tumor infiltrate. If you see on the left side, there is a high expression of B4H7, which is similar to PD-L1, very immunosuppressive. There is a CD8 population to some degree, but not much CD8 cytotoxic cells, very few CD4 cells. So it seems that there is a tumor infiltrate in the ovarian clear cell carcinoma. It is largely immunosuppressive. Ongoing work actually shows that even CD8 cells that are present in this environment, they're not functional because they're surrounded by other immunosuppressive environment. So that what that leads us to in summary is that it seems that there is a progression from endometriosis to clear cell carcinoma or if you want, from a typical endometriosis to clear cell carcinoma that goes from the niches that are characterized by chronic inflammation and increased oxidative stress, and that creates the environment that's really primed for genetic alterations to, from that point, lead malignant transformation. The tumor environment then has a very complex interplay, but significant role because tumor infiltrate seems to be there, but it is suppressive. And with these 3 points, I think our opportunity is not only in really finding new treatments for clear cell carcinoma, which are very complex. It's a complex task because of everything we know about the genetic evolution in this tumor type, and because of this very complex interplay between tumor microenvironment, immune infiltrate, and genetic alteration. So while we are working on combination treatments, on figuring out the role in immune therapy and how it can be combined with maybe targeted treatment, there is possibly a role for prevention of this disease, which would be great. And to me, it looks like if we can achieve something similar as in colon cancer, where we have a model going from colonic polyps to colon carcinoma, if that really exists here as it is, from benign endometriosis to typical to cancer, then really prevention may be our worthy goal. So does it, and as I suggested, like, is it possible to, or is it worthy to determine RID1 loss, to detect it by immunocytochemistry, to screen cases of atypical endometriosis? Is it worth doing molecular profiling in broad sense on atypical endometriosis? And is there a chance that we use liquid biopsy and cell-free tumor DNA or tissue DNA to find changes in blood before associated with high-risk endometriosis that can turn to ovarian cancer? And with that, I will close and take questions, or we can wait for questions at the end of this session.
Thank you, Tanja, for a great presentation. We can do both because what I understand, we don't have one speaker. So it's up to you, it's up to the speakers. All right, it's my great pleasure to introduce our second speaker, Dr. Farr, who is the medical director of the...
You don't have to introduce me. I have introduced before.
Okay, sorry.
Everybody knows who I am.
Sorry, thank you for letting me know.
No, thank you very much. You want to save some time. So, thank you very much. I appreciate it. The reason we chose this subject to present, because as you have been hearing for the past 3 days, endometriosis is a very complex whole body disease. And one of the aspects that now we realize more and more that endometriosis is a risk factor for cancer, or could become malignant, and especially for ovarian cancer. So this has been my passion for almost past 30 years, and I have published about it. So because it's so common, but at the same time, I don't want to scare patients with endometriosis to have cancer, because cancer is a scary word. And because we have some patients in our audience, so I will try to share with you some clinical application of this malignant transformation of endometriosis to keep in mind. Dr. Rosati, that is follows me, will talk about the statistic, about epidemiology. Dr. Pejovic specifically talk about the clear cell type of ovarian cancer. So at the end, you could put all together. So I just like to present to you 2 cases that I have taken care of them for the past several years. One of them was a patient that she was 38 years old when she came to me. You could read the history. She had history of endometriosis, tried to get pregnant. I gone to the infertility physician. They did the MRI. I got lateral ovarian endometrioma. Was treated with Lupron for 3 months and didn't respond. And finally, she was referred to me for treatment. You heard the previous speakers. They do transvaginal ultrasound, some gynecologists. I do my own transvaginal ultrasound. And when she came to me, I did the ultrasound, and I noticed this nodule in the ovaries, in the endometrioma, and this was a nodule that I said this could be malignant. So I did laparoscopy on her, and during my laparoscopy, I opened the left ovary and had this nodule, and I took a biopsy, and it came back cancer. So she was infertility, and before the surgery, she said, do not remove my ovary. That is was important, that this is an agreement we have made. So I did some laser adhesion, took a biopsy. This was cancer. The right ovary had a cyst. We removed it, and the final pathology came back that she had adenocarcinoma. It was a stage 2. So, like any other cancer, we have a tumor board. We discuss what to do, and finally we decided that she wants to get pregnant. She was sent back to her infertility physician. They got some eggs from the left ovary. Actually, the right ovary didn't respond to the stimulation. Got some eggs, and then she came back to me, and then I went to the staging and removed that ovary, left, right tube. I kept the uterus. She got chemotherapy, and after 1 year, she went back and transferred 1 embryo, and that was successful. And they had this baby, and actually we published this paper, and it is more than 10 years that she is doing fine. So the message is that the patient is infertility and has ultrasound, and she has a suspicious lesion. It has to be evaluated. But it was a good news for this patient. This is another case. Actually, this is Dr. Rosati. Several years ago, she referred this patient to me. This is a patient that had endometriosis, infertility, tried, never got pregnant, and finally she went to menopause, and she forgot about getting pregnant, and she was followed by her gynecologist. She had abdominal pain for a couple of years, and they were saying that this was a scarring endometriosis, and nobody did anything on her. Finally, after 2 years, she came back with ascites, and the CT scan showed that she had a metastatic disease. And that is a patient that, when it was referred to me, I do laparoscopy in all of my ovarian cancer patients, and then you could see that she had metastatic disease everywhere. She had ascites, and we took a biopsy, and that was unfortunately clear cell carcinoma, as Dr. Pejovic was mentioned. She was advanced disease, and clear cell carcinoma, as we discussed, does not respond to chemotherapy well, and in spite of aggressive surgery, cytoreductive surgery, and chemotherapy, she did not respond well, and she finally died. So, if you endometriosis for past 2 days, 3 days, you have been hearing that it is very common to the different areas, and majority of malignant transformation of endometriosis are on the ovaries. But in the literature, any part of the body that endometriosis has been shown, malignant transformation has been reported. Dr. Rosati will briefly describe to you what is the mechanism of transformation. We don't know completely, but it seems to be a combination of the genetic abnormality of the cells of endometriosis and inflammation and high level of the estrogen makes this process to happen. So, on the ovaries, there are the history of the endometriosis, the fertility medication, therapy. These all could be risk factor for malignant transformation. Dr. Pejovic briefly mentioned, if you look at the ovarian cancer, there are different types. The most common types are epithelial type of tumor, and epithelial type of tumor are two types. We call them type 1 and type 2. Type 1 are coming from the fallopian tubes. The fallopian tubes, called high-grade serous carcinoma, are the source of the type 2. Type 1, that they are clear cell and endometrial carcinoma, it seems to be background is endometriosis. So endometriosis is a risk factor for certain type of the ovarian cancer. In a paper that we published, look at 76 patients that they had a stage 1 ovarian cancer, and we look at the background of this patient. Of those patients that they had non-serous cancer, they had 2/3 of them, they had endometrial and clear cell carcinoma, and the background was endometriosis. And interestingly enough, 1/3 of those patients also had endometrial hyperplasia or endometrial cancers. So majority of the clear cell carcinoma and endometrial carcinoma are background or endometriosis. Now, so put all everything together, what do we do? If you look at the lifetime risk of a woman developing ovarian cancer by age of 70 is 1.4%. And we know by now that high-grade serous carcinoma, some of them they have genetic abnormality like BRCA1 or BRCA2 mutations, and this the risk is 60% or 30% for BRCA2 mutation. Hereditary non-polyposis, colon cancer, or Lynch syndrome, the risk is 10%. We have protocol for these types of the patient, and at certain age, we recommend to have remove tube and the ovaries. But statistically for endometriosis, fortunately, the risk is not that high. Only 2 or 3% compared to general population, patients with endometriosis have risk of developing ovarian cancer. So number one message is that not every patient with endometriosis has to remove the ovaries. That's the number one message. Now, what else is important? As you guys all know, unfortunately, at the present time, we don't have any screening test for ovarian cancer. The same way we don't have any screening test for patients with endometriosis to see which one develops ovarian cancer. CA125, that some people are using it is at the present time, it is not good test. So do not do CA125, because CA125 is elevated in endometriosis very frequently. But how could we try to decrease the risk as much as possible? So I talked 2 days ago about the pathophysiology of ovarian endometrioma, and I mentioned that majority of them are coming from the ovulation, the type 2. So if the patient has type 1, type 2 endometrioma are coming from the ovulation. So if the patient has endometriosis, we recommend to put them on suppressive therapy. If they could tolerate suppressive therapy. And the literature has shown very well that the patients that they are on birth control pills, the risk of the ovarian cancer is less. So that's number one message. The other thing is that right now, we recommend to remove the fallopian tubes in patients that are going to have surgery, for example, have a hysterectomy. We recommend to remove the fallopian tubes. Also, frequently, more and more, we recommend to remove the fallopian tubes when the patient is going to have his tubes tied. Instead of clipping the tube, we recommend to remove the fallopian tubes. Why? Because briefly, as I mentioned, majority of the high-grade serous cancer coming from the fallopian tubes, so we remove fallopian tubes. Also, retrograde menstruation and inflammation that is being transmitted to the pelvis and is the source of the clear cell and endometriosis carcinoma. So if you remove the fallopian tubes, you are preventing both high-grade serous carcinoma and also endometriosis and clear cell carcinoma. And whenever there is opportunity that you do remove the fallopian tube, if it is through surgery for endometriosis and the tubes are damaged, and the patient is going to have IVF because the IVF is so successful, and the tubes are damaged, you recommend to remove the fallopian tubes. Actually, we published a paper recently, and we looked at the incidence of the fallopian tube endometriosis, and also by laparoscopy, it doesn't look a lot at the fallopian tube has endometriosis, and we did a prospective study in 88 cases, and you could see that the patient, and we look at the one item fallopian tube endometriosis, and we look at the different layers of the endometriosis, you could see an incidence of fallopian tube endometriosis actually is very high. So when you operate, for those of you who are surgeons, and the fallopian tubes are involved in severe adhesion and hypersalpinx, and the tube has endometriosis, maybe you want to talk to your patients before to remove the fallopian tube. What else can be done? The other thing is that we think whenever there is endometrioma is the tip of the iceberg. And we all have been talking for the past few days that endometriosis, the more you remove, the better patient has results regarding the improvement of the pain and also infertility. Again, a paper that we published not too long ago, and we look at the 222 patients, and we look at the stage of endometriosis, and we found of these 222 patients, 86 of them they had endometrioma at the stage 3 and 4 endometriosis. So endometrioma is the tip of the iceberg. We recommend whenever there is endometrioma there, remove them and clean the pelvic endometriosis. If the patient wants to get pregnant, of course, he just get pregnant. Doesn't want to get pregnant, put them on suppressive therapy. It's a very important study was published by Mellon from Sweden, and they looked at the risk of the patient developing ovarian cancer based on their history of the endometriosis, on the peritoneal endometriosis or the endometrioma. And they found that they followed those patients 1 year. They found out that one-sided oophorectomy involving endometriosis decreases the endometriosis, malignant transformation of endometriosis by 81%. And also, if they removed peritoneal endometriosis completely, decreases the risk of that patient developing ovarian cancer is by 70%. And that makes sense, because when the more remove the disease, remove the inflammatory process, and estrogen production decreases the risk. So whenever you do the surgery, and the patient has to, as much as possible, you remove the endometriosis of the peritoneal endometriosis. And if the ovary is severely damaged, if the patient has to have his infertility, you may want to get eggs before. So putting all of this together, you have to select your patient when you operate. And the last thing I want to mention about the diagnosis and the endometrioma, this is endometrioma, which was followed. She was not being removed. Few years later, she developed this abnormality. So whenever you want to remove the endometrioma, there are two characteristics that makes that warn you that this is a malignant transformation of endometriosis. One is that the characteristic of the smooth, homogeneous endometrioma become heterogeneous characteristic, and it forms a nodule. It is called mural nodule. And the MRI could be sometimes more useful than ultrasound to identify that solid component in the endometrioma. This is we call mural nodule on the endometrioma that has to be evaluated. If you have endometrioma and develops this characteristic, this has to be surgically removed. The other characteristic is that if the endometrioma all of a sudden gets bigger, like my patient that in spite of being on Lupron, the endometrioma got bigger, that was cancer, is another example. This is a patient that had this cyst, and you could see it had a small nodule too, and this was not removed. 9 months later, this cyst became, you could see, much bigger, and had still the nodule. And when she was referred to me, and I did the laparoscopy, and this was a big nodule, and this was clear cell carcinoma. Fortunately, that was removed, and she was early stage, and she responded to surgery and chemotherapy. And finally, about the treatment of this malignant transformation, this is based on the surgery. You should all have to, of course, refer to the GY oncologist. Surgical site reduction and staging is the first step. Then based on the stage, some of them we do observation. Endometriosis carcinoma respond to chemotherapy very well. Clear cell carcinoma doesn't respond well to chemotherapy. Some of them respond to radiation, and these days target therapy and immunotherapy, it has to be used and individualized for each case. Thank you very much.
Thank you, Dr. Nezhat, for a very informative presentation. So I just learned that today we have only 2 speakers, and so we are ready to start the Q&A session. Please.
Dr. Rosati, do you want to give the talk? Yeah. Dr. Rosati is going to also cover some of the aspects, okay? Just okay. You sure that you? Okay, I think this is it. Okay. This is a point. This is
okay. So, good morning, everyone. Thank you for being here, and thank you for the kind invitation. Let me see when for changes there.
Yeah.
Next. Okay. So, the points to be addressed in this presentation are as follows. Is there an association between endometriosis and cancer? Is endometriosis a precursor of ovarian cancer? How should we manage and follow up patients with endometriosis concerning the risk of ovarian cancer? Now, many of these arguments are already treated, but I will try to make a synthesis of that. The first point is there an association between endometriosis and cancer? Of course, patients with endometriosis appear to be at increased risk of developing certain types of cancer. And there seems to be a very small and borderline statistical significant association between endometriosis and breast cancer, and a robust significant association between endometriosis and thyroid cancer. Now, although the absolute risk of developing a cancer in a woman's life in women with endometriosis is slightly higher for these 2 types of cancer. As regards an association with other tumors of the reproductive system, there is no statistically significant association with endometrial cancer, and even patients with cervical cancer seems to have a significant lower risk of cervical cancer. In conclusion, patients with endometriosis show a higher risk of breast cancer and thyroid cancer. However, the absolute risk of these cancers is low. Now, the second point is, can endometriosis undergo malignant transformation? Endometriosis and cancer have several things in common. They both spread locally and at distance, and resistant to apoptosis and invade surrounding tissue. The first to investigate whether there is an association between endometriosis and cancer was Samson, who already in 1925 listed the following criteria to attest this association. And in fact, it has been seen that a malignant transformation of endometriosis happens, and it happens in 0.7 to 2.5% of women. Now, 75% of this endometriosis associated malignancy are ovarian, and 18 and 25% are estrogen. This show that the possibility of cancer in other location is possible, and this neoplasm, as the previous speaker told you, are usually endometrioid and clear cell carcinoma. Now, endometriosis is also associated with urinary tract. In one study of these authors, 11 cases was found in the bladder and 4 cases in the ureter. And even endometriosis associated malignancy was found in surgical scars. This is a rare but aggressive phenomenon with a median blood time from surgery of about 19 years, predominantly clear cell endometrioid carcinoma. About epidemiology, the previous speaker showed you. This is one of the largest review and meta-analysis, and I want to show because this is show that there is a particularly strong association between clear cell carcinoma of the ovary and endometriosis. And anyway, the absolute risk of developing an ovarian cancer in a woman's life is double in a woman with endometriosis. Now, okay, the point is that in the studies evaluated, endometriosis associated, okay, to ovarian cancer is defined as one of the following three conditions. That detection in the same ovary of endometriosis and ovarian cancer, detection of endometriosis in one ovary and of ovarian cancer in the other, coinciding with the identification of ovarian cancer in any of the ovaries and pelvic endometriosis. Now, what we don't know at the moment, we don't know many points, and specifically, which patients are at higher risk of endometriosis turning into ovarian cancer. Could we clinically identify patients with endometriosis associated ovarian cancer? And are all endometriosis associated ovarian cancer arising from an endometriotic lesion? And could we clinically distinguish patients with ovarian cancer arising from endometriosis from patients with ovarian cancer just associated with endometriosis? Now, another point is is there a precursor of ovarian cancer in the endometriotic lesion? How to recognize patients at high risk, how to follow them over time. To this question, whether endometriosis is really a precursor to ovarian cancer, we can answer yes. The factor that intervene and are therefore responsible for the transition from benign to atypical endometriosis to borderline into cancer are mainly environmental problem, angiogenesis, immune cause, and all this process promotes genetic alteration, driving progression to cancer. And this process includes the inactivation or activation of genes. The previous speaker spoke about these genes, so I want to not to repeat the same. But for example, we have to think that for the gene PIK3CA, the regulation of this gene is like to give a gas pedal for the cell growth. I mean, it increase the cell growth. I don't know if it's clear, the concept. So, atypical endometriosis is the link between endometriosis and ovarian cancer. Patients with atypical endometriosis are high-risk patients. This study, which has conducted on a very high number of patients, aimed to highlight not only the association between ovarian cancer and endometriosis, but also to make a distinction between the type of endometriosis with the highest risk of ovarian cancer. It was seen that the type of endometriosis with the highest risk, in the ovarian, are in the ovary and in deep infiltrating endometriosis. In particular, it was evident that the significant association of this type of endometriosis was with the type 1 carcinoma, endometrioid clear cell or low-grade serous, with a risk increased by approximately 17, a situation similar to that of patient carrying the BRCA gene. Anyway, these data are confusing and could be a bias because these are taken from electronic database and could be dangerous because these studies could lead clinicians to be very aggressive from a surgical point of view, with inevitable consequences in terms of intraoperative, postoperative, and long-term complications, inducing in some person removing ovary to an early menopause with the cardiovascular, osteoporotic, and genetic urinary risk. And so for what? For very small absolute numbers. For this reason, the research has been focused in detecting patients at high risk. The previous speaker, Farr explained the concept. I think that it's useless that I repeat that we have three groups. One group is endometriosis correlated ovarian cancer. Another group is endometriosis incidental to ovarian cancer. And another one is ovarian cancer non-associated with endometriosis. And even macroscopically, this group appear different from each other. You see a very smooth surface of endometriosis-associated ovarian cancer on the left side of the slide, and vegetation more often found in ovarian cancer non-associated to endometriosis. But also, they found that in this group, that from the point of view of the characteristic of the patient, endometriosis associated of ovarian cancer are younger, and endometriosis correlated to endometriosis are more difficult to conceive, of course. Another point is that the marker CA 19.9 was higher in the endometriosis-related ovarian cancer group. And this group was diagnosed at earlier stage of carcinoma with different types of surgical approach and survival rate, as very well shown by Farr. And in this slide, we show how the CO 19.9 in this group of related ovarian cancer is statistically higher. Now, what is the impact on survival between endometriosis-associated ovarian cancer and ovarian cancer not associated to endometriosis? Although a longer follow-up is needed, the first data show a better progression-free survival in ovarian cancer associated with endometriosis. Therefore, it would seem that endometriosis-associated ovarian cancer and ovarian cancer not associated are two different clinical entities. We saw this also in a morphologic expression of these two pathologies. And this table shows, in fact, how the recurrence rate of endometriosis are associated with ovarian cancer are different from those of ovarian cancer not associated with endometriosis. This graph shows better how the outcomes are better in endometriosis associated with ovarian cancer, both in the early and advanced stages, both in terms of progression-free survival and the overall survival. This is another study that showed the same data. Now, how should we manage this patient? Surgery, always and in any case, observation. In our department, I just want to tell you that we offer more frequently surgical treatment because we perform this kind of procedure in sedation without any spinal or general anesthesia with a few hours and with a very high satisfaction for the patient. But there are those who suggest a conservative treatment. In the IOTA-5 study, with a 2 years follow-up, no malignant endometrioma and endometriosis mass was observed, but it is a too short follow-up, we believe. We have seen that the most frequent affected patients are menopausal patients because the malignant transformation process requires longer time to be established. And indeed, in this study, of 6,000 more participants with a period follow-up of up to 17 years, in 46 cases, a malignant transformation was observed, and with a statistically significant association with the tumor size greater than 9 centimeters and menopausal status. Now, I just want to go, I don't want to, because otherwise it's too long, and they asked me to be short, to shorten the presentation. And I just want to show, this is a slide where patient diagnosed with atypical endometriosis to malignant transformation during the follow-up period. And but I want just to jump to another, because otherwise it's too long. And this is the same article, the same paper that Dr. Farr presented to you. This is a Swedish publication, and so, okay, this is a proposal on management. We identify patients at high risk, diagnosis of endometriosis more than 45 years, recurrent endometrioma, larger size of endometrioma, more than 9 centimeters, previous diagnosis of atypical endometriosis. Now, the proposal is that women less than 45 age can have gonadal conservation, and women more than 45 age can have another approach or alternatively close surveillance with or without progestogen treatment, or removal of the ovary or the serpins in this case. To date, however, this higher risk identification is not very specific and effective, so other studies are underway to identify patients at risk. The search for microRNA, MIRNA, could provide potential biomarkers for the early transformation of endometriosis toward endometriosis-related ovarian cancer. What are MIRNA? MIRNA are small non-coding RNA molecules containing about 22 nucleotides, providing post-transcriptional regulation of gene expression, taking part in several biological processes, including cell proliferation, differentiation, and apoptosis. And it was seen that there is a statistically significant upregulation of MIRNA involved in malignant transformation, and in particular, we found 8 MIRNA fragments identified which discriminated malignant lesion from benign one in an excellent manner. These studies was carried out on ovarian tissue, but new publication show that the possibility to translate and validate this result on the saliva in order to easily identify the patient at greatest risk. That is, those patients who express this MIRNA more. I jump just on the conclusion. I want to shorten my presentations, and also the European guidelines. And anyway, the surgery, preventive surgery, risk-reducing surgery is not recommended from our society. The prevention is not useful. The conclusion is the patient with endometriosis show a higher risk of ovarian cancer. Endometriosis-associated ovarian cancer seems to have a better prognosis compared with ovarian cancer not associated with endometriosis. Management of endometrioma should be personalized. Counseling is crucial to inform patients with endometriosis about their cancer risk and modality of surveillance. And detection of biomarker of MIRNA in saliva or blood could serve as an early way for identifying patients at risk for malignant progression of endometriosis. Thank you for your attention.
Thank you, Dr. Rosati, for your presentation. I think we can move to the Q&A session. Please ask your question.
Hi, thank you for these presentations. I'm a patient, so just setting the context in case my question sounds silly. But we keep talking about that endometriosis mimics cancer, but it can spread to any part of the body, it can invade organs, it causes inflammation, fatigue, it can come back, so there's recurrence, but we never classify it as a type of cancer. What is that differentiating property that this is not considered a type of cancer?
So can you repeat your question about
I guess I'm trying to ask, when I talk about endometriosis with my friends, I say that, oh, they can be recurrence, it causes inflammation, it can spread in any part of the body. So it sounds like cancer. Yet when when doctors talk about it, they only say it mimics cancer, but it is not cancer. What is that differentiating property? Like, why is it not classified as a type of cancer?
That's a very good point. Cancer kills the patient. Very simple. If you don't not treat it. Endometriosis, it doesn't kill the patient. In a simple way. We call it, both of them, if you look by surgical manifestation, the invasion of the cells in the peritoneum is cancer similar to endometriosis. But the endometrial cancer that causes catabolic effect on the body. So that is the reason that the cancer kills the patient, but endometriosis, it doesn't. It causes pain, infertility, all kinds of issues. That's it.
Hi, thank you so much for the excellent presentation. I have a question for Nezhat. I was a fellow with Dr. Nezhat like 8 years ago. I still have questions for you. So for the postmenopausal patients, they have like a large endometrioma, and apparently they have no pain anymore. And so when I counsel them, they have the risk of a clear cell carcinoma. And at this point, what do you think? What's your suggestion? Should I just continue observe them, or some patients are very nervous and they want me to remove their ovaries? And what's your suggestion, Dr. Nezhat?
That's a very good point. In our tumor boards, the oldest patient that I have had is 85 years old. That was malignant transformation of endometriosis. And once I was giving this talk somewhere, somebody presented a case of, she was 92 years old and had malignant transformation of the appendix. So the short answer to your question is that postmenopausal patients, this endometriosis, no matter it is in the ovary or in the peritoneum, could become malignant. But which one, we don't know at the present time, unless the mRNA that Dr. Rosati mentioned could give us some maybe liquid biopsy. Endometrioma in postmenopausal, if you don't want to remove it, the only way to see if it becomes malignant or not, to the ultrasound or MRI. But if it was me, I remove it.
But the only question is that if I do the surgery, should I just take over the whole thing out of the ovaries? Or I have to treat like a radical treatment of endometriosis, all of the endometriosis, just.
I remove everything. I remove all endometriosis.
All of them.
Yes.
Thank you.
If you don't have any questions, thank you very much. We go to the next session, which is the keynote speech. The senior Nezhat to present this. Thank you very much.
Well, as we connect, it is my really pleasure to introduce Dr. Stacy McAllister. For all of you, just know she's been part of the scientific committee, excellent suggestion, impact on looking at non-surgical aspect and immunological aspect. She has a PhD in neuroscience, and then she did additional studies at Stanford University. Her focus has been pain. They did a study on the rat models, they call it vaginal hyperplasia related to endometriosis cell, which relates to dyspareunia. So she had NIH grants, and her work is phenomenal. Right now, she is associate professor or assistant professor at Emory University, where I had the pleasure of we collaborate together on endometriosis tissue related not only to pain, also looking for drug development and products for the management of endometriosis. So I'm not here to tell you how great she is. I'll let you listen to yourself and you will know she's better than I could ever describe. Thank you, Stacy.
Thank you so much. So thank you so much first for the invitation. My name is Stacy McAllister and I'm from Emory University. And so today for this talk, I'll discuss how integrating
preclinical models with patient-derived data can help identify biological mechanisms underlying endometriosis-associated pain, and also to inform the development of targeted therapies. So as most people here are aware, the statistics, symptoms associated with endometriosis, I do think it's important to just briefly mention that endometriosis is a major global health problem. It affects approximately 200 million women or individuals worldwide. The primary symptom is pain, which can be severely debilitating. The diagnosis is up to 10 years, which unfortunately prolongs patient suffering and delays effective care. And for many patients, endometriosis has a profound impact on quality of life, daily functioning, and productivity, as I believe it was Quincy, Lily, and Ellen last night at the gala. I think they described that wonderfully. Also, although surgery and clinical care remain essential, we still need a better understanding of the biology underlying pain and the treatment response. So experimental models help fill that gap by giving us tools to study mechanisms and allow us to evaluate therapies in ways we cannot do directly in patients. So these tools serve as a bridge between patient experience and better targeted care. So one of the major challenges with endometriosis-associated pain is that it is complex. Pain severity often does not match visible disease, and so lesion burden does not fully explain symptoms. Also, there is substantial heterogeneity in clinical presentation, with patients differing in pain type, severity, persistence, and treatment response. So the underlying biology is multifactorial, involving more than lesion presence, along as Dr. Nisha Lackey laid out for us yesterday so nicely in her presentation. Taking together, this suggests that pain arises from multiple interacting mechanisms, including both peripheral processes within the lesion microenvironment and central alterations in pain processing. So overall, this is a biologically complex pain state, which makes treatment difficult. It highlights the need for mechanism-based approaches. And it's also a key reason why experimental models are important to help us understand what is driving these symptoms. So given the complexity of endometriosis-associated pain, it's important to consider the current therapeutic landscape. Effective surgical and medical treatments are available, and they can provide meaningful benefit for many patients. But at the same time, many patients continue to experience incomplete relief and symptom recurrence. So taken together, this highlights the need for mechanism-based therapies that complement existing surgical and medical care. So that need for mechanism-based therapies is what motivates research in my lab, which is a translational lab. And so that is our approach. And to address this gap, our work integrates patient-biased specimens and clinical observations with controlled preclinical models. So we use an iterative translational framework in which patient data guides our questions that we ask, and then we use complementary rodent models, which allow us to test those mechanisms experimentally. So these model systems make it possible to study pathways not feasible to interrogate directly in humans. And when we use these findings, you can identify therapeutic targets and study pathways not feasible, again, to interrogate in humans. In this way, the process is really bidirectional, and it's designed to keep discoveries both biologically grounded and clinically relevant. And so using this bench to bedside framework, we became particularly interested years ago about the involvement of oxidative stress, and more specifically, how aldehyde-related biology could be a candidate mechanism linking endometriosis to pain. So briefly, oxidative stress is elevated in women with endometriosis, and it can generate products of lipid peroxidation called reactive aldehydes, especially 4-hydroxynonenal, 4-HNE. So reactive aldehydes are important because they can amplify inflammation and promote nociceptor sensitization and ultimately contribute to pain. So this pathway is an attractive target, not only from a mechanistic standpoint, but also because it represents a therapeutically actionable target. And so because oxidative stress generates reactive aldehydes, we then ask what regulates their accumulation. And so this led to our focus on ALDH2, or it's aldehyde dehydrogenase 2 enzyme. It's a key mitochondrial enzyme responsible for detoxifying reactive aldehydes, especially 4-HNE. And so what we found is that, if ALDH2 is sufficient, then these toxic reactive aldehydes are converted to less reactive forms and cleared within tissues and peritoneal fluid. However, when ALDH2 function is reduced, reactive aldehydes accumulate. And with that buildup, enhanced downstream pain signaling, and ultimately, this may lead to the contribution of pain. So thus, ALDH2 represents a key biological regulator link, linking oxidative stress to pain and potentially, importantly, an actual therapeutic target. So based on this framework, we developed our central hypothesis that impaired reactive aldehyde detoxification contributes to lesion pathology and pain and endometriosis. Specifically, we propose that oxidative stress increases reactive aldehydes such as 4-HNE, and insufficient ALDH2-mediated detoxification allows reactive aldehydes to accumulate and promote downstream disease and pain-related processes. So first, to test our hypothesis, we wanted to ask whether this pathway was altered in women with endometriosis. And so using these biospecimens, we examined 2 related measures. So on the left here, we measured ALDH2 activity. We found that ALDH2 is markedly reduced in both UTOP and lesion tissue from patients with painful endometriosis, and this was compared to individuals without endometriosis and without pain. And so on the right, this is H&E adducts. Well, so these are protein modifications that form when reactive aldehydes accumulate. So we found the opposite pattern from ALDH2, where H&E is significantly increased and is highest in ectopic endometrial lesions. So taking together, this data supported that reduced reactive aldehydes, detoxification, increased aldehyde burden, and painful endometriosis. But because patient biospecimens show association rather than causation, we felt it's important to turn to then animal models to test whether this pathway mechanistically contributes to pain. And so to do this, we use a genetic mouse model. It's an ALDH2 knock-in mouse, and it has reduced ALDH2 activity. And so what you can see here in this graph, so the blue mice are indicating wild-type mice, and the red is the ALDH2 mice with the reduced ALDH2 activity. What we found was at baseline, the abdominal pain-associated behavior was low in both groups. But after endometriosis was established, abdominal pain-related behaviors increased, and that increase was significantly greater in mice with the reduced ALDH2 activity. So this supported our idea that impaired reactive aldehyde detoxification is not just a correlate in human tissue, but also may functionally contribute to pain. And then we asked whether lesion aldehyde burden relates to pain severity in this model. We found a strong positive correlation. So as lesion H&E, 4-HNE increased, abdominal pain-associated behaviors also increased. So this sort of added another layer of support for the pathway and suggested that higher local aldehyde burden within the lesion is associated with greater pain severity. And importantly, this connected the biochemical signal in lesions to the behavioral pain phenotype. So after seeing that lesion H&E tracked with pain severity, we next asked whether increasing ALDH2 activity could reverse that biochemical phenotype. We used pharmacological activation of ALDH2, here it was chemical ALDA1, to test whether increasing ALDH2 activity could reduce lesion aldehyde burden. And so what you can see on the left is that ALDH2 activity increases with treatment in both the wild type and starchy mice. And in the middle, lesion for H&E addict formation shows the opposite pattern, decreasing with treatment, including the starchy mice with reduced ALDH2 activity. The representative plot on the right supports that same overall pattern, and our key point here is that increasing ALDH2 activity not only improves the pain phenotype, but it also restored pathway function and reduced lesion aldehyde burden. So we next asked whether enhancing ALDH2 activity could also improve the pain phenotype. And so here, the answer was yes. And both wild type and starchy mice, treatment reduced abdominal pain-associated behaviors compared to vehicle. Vehicle here was our TMSO-treated mice. The effect was especially notable in our starchy mice with a more pronounced endometriosis pain phenotype. And so these data provided the functional complement to the prior biochemical data, so that when ALDH2 activity is increased, not only is aldehyde burden reduced, but the pain phenotype is improved. So taken together, these findings support ALDH2 as a mechanistically relevant and potentially actionable, which led us to then consider broader translational implications. To do that, we brought on our rat model. So with the rat model, this brings on endometriosis-like lesions, and it also brings on persistent endometriosis-associated vaginal hyperalgesia, also can be referred to as vaginal pain, but it provides a more chronic and clinically relevant phenotype. So here the black curve shows a baseline response, the red curve shows the response after endometriosis has developed and stabilized. So what you can see is that there's a clear left shift in the red curve, meaning that the rats will show escape responses at lower vaginal distension volumes. And what this ultimately means is that there is increased vaginal sensitivity that develops in this rat model that persists. So we then asked whether this persistent pain phenotype could be improved therapeutically. So this slide here shows the effects of modulating ALDH2 in both directions. On the left, this is our vehicle condition. As expected, vehicle treatment did not mainly improve the post-endo pain phenotype. In the middle, ALDH2 activation. The post-treatment curve shifts to the right towards baseline, indicating reduced vaginal pain sensitivity or hyperalgesia. And on the right, with the ALDH2 inhibition with disulfiram, we see the opposite effect. And so the post-treatment curve shifts left, indicating exacerbated pain. And so the key point here is that ALDH2 modulation changes the phenotype in a bidirectional way. Activation improves pain, whereas inhibition exacerbates pain. So now, having shown that the ALDH2 modulation can shift the pain phenotype in both directions, we next asked whether those behavioral changes were accompanied by differences in lesion aldehyde burden. And so what we can see here on the top is the ALDH2 activity. With ALDH2 activation without a 1, ALDH2 activity was increased relative to vehicle. Whereas with disulfiram, indicated with DSF here in this chart, ALDH2 activity decreases. And with on the bottom, we see that complementary pattern for 4-HME adduct formation. So with ALDA1, lesion H&E is reduced. With DCSF, lesion H&E increases. So the key point here is that these pain changes are mirrored by bidirectional changes in lesion biochemistry. So activating ALDH2 increases ALDH2 activity and lower aldehyde burden, whereas inhibiting ALDH2 does the opposite. So this helped us link the behavioral phenotype with a molecular readout within the lesion itself. And so we next asked whether these lesion level molecular changes were related to hyperalgesic severity. And so what we did find is that on the left, there's a strong inverse relationship between ALDH2 activity and hyperalgesic severity. In other words, lower ALDH2 activity is associated with a more severe pain phenotype. And on the right, we see the complementary pattern for H&E addict formation. And here, higher lesion for H&E is associated with greater hyperalgesic severity or vaginal pain. So taken together, these data show that lesion biochemistry tracks closely with the pain phenotype. Overall, less ALDH2 activity and more aldehyde burden are associated with worse hyperalgesia. And so this really strengthened our link between the molecular changes with the lesion and the behavioral pain outcome. So while lesion biochemistry tracked closely with pain severity, we next asked whether the same was true for conventional measures such as lesion burden and lesion number. And we found neither lesion number nor lesion burden significantly correlated with the hyperalgesic severity. So this was consistent with what is often seen clinically in women with endometriosis. The extent of the disease burden alone does not completely explain pain severity in this model. Instead, these data suggest that the biochemical state of the lesion is more informative for pain than lesion burden or lesion number. And so this shifted our focus from how much disease is present to what biologically is going on in these lesions. And so together, our findings support this model in which reduced ALDH2 activity leads to aldehyde accumulation, greater oxidative stress, and nociceptor sensitization, and ultimately more pain. In contrast, enhancing ALDH2 activity shifts that pathway in opposite direction. So this working model is also supported by our cross-species convergence. So we saw convergence across human tissues in two complementary rodent models. Briefly, the patient tissues observed reduced ALDH2 activity with increased 4-H&E addicts, and the ALDH2 knock-in mouse. We saw reduced ALDH2 function was associated with more severe pain, and in the rat model, modulating ALDH2 produced by bidirectional effects with activation improving pain and inhibition exacerbating pain. So across all species, the same overall pattern emerged, and that was impaired reactive aldehyde detoxification was linked to endometriosis-associated pain. And this is important because it strengthens confidence that this pathway is mechanistically relevant and not limited to any one system. And so that brings us to therapeutic implications. So our findings suggest several therapeutic implications. So first, the pathway points to a mechanism-based innervation that targets aldehyde metabolism directly and may represent a non-hormonal therapeutic strategy. Second, because the pain phenotype appears to be more closely linked to lesion biochemistry than lesion burden, this approach may be especially relevant for persistent or refractory pain and may help pain that is not explained by lesion burden. And third, this is not necessarily a replacement for current care, but rather a complementary strategy that could help within a broader multimodal and personalized treatment approach. So more broadly, these findings may also help us move the field forward towards more precise biology-informed care, where biomarkers and ALDH2-related variability could eventually help identify patients most likely to benefit from mechanism-based treatments. So to close, I'll leave you with a few main take-home messages. First, endometriosis-associated pain is complex, underlying biology with inflammation, metabolic and neural mechanisms likely shaping the pain experience. And second, reactive aldehyde metabolism and specifically ALDH function may represent a novel biological pathway that may contribute to endometriosis pain. And we are seeing encouraging cross-species convergence across human tissues and rodent models, all pointing to the same underlying mechanism. And these insights suggest that a targeted, more mechanism-based approach that may help move the field forward with more precise and biologically informed therapies for endometriosis. So with those key messages in mind, I'm going to end here by highlighting current and ongoing work in our lab. So what we're doing now is we're first validating aldehyde-related biomarkers and patient cohorts to determine whether these signals are robust and clinically informative. We're also expanding studies in endometriosis tissues and peritoneal fluid to better understand how this pathway relates to the local disease environment and pain biology. Our findings are also helping guide aldehyde-targeted strategies as potential mechanism-based approaches. And importantly, we are advancing translational studies with Dr. Sina Nezhat and the Nezhat Medical Center to connect mechanistic biology with carefully characterized patient samples. And so overall, our long-term goal and our hope is to move the field from treating endometriosis pain empirically to treating it mechanistically. And with that being said, I'd like to acknowledge my lab members and importantly, our collaborators, particularly Sina, Dr. Nezhat, who is key in obtaining these very important samples that are a basis of some of our studies, and as well as our NICHT grant funding that is supporting our work. With that, I'd say thank you.
I told you you're gonna love this talk. So even though for keynotes we normally don't do QA, but I am curious. If that's okay, I'll ask you a question. How do you measure dyspareunia in the rats? How do you measure dyspareunia in the rats?
It's rather complicated. The training itself takes about 6 weeks. And so
Speak to the microphone.
Okay, sorry. So the training takes about 6 weeks. The distension is a vaginal balloon that is delivered to the rat's vaginal canal. And so it's 8 different volumes delivered randomly, a 1-hour testing session. And so you do this at baseline, and each volume is delivered 3 times each. So you have an escape response, which is 1 out of 3, so it's 33, 66, or 100%. And so you collect this data at baseline, and then and you do it as they're developing endometriosis because you're seeing sensitivity increase. But at 8 weeks, it stabilizes, and so at that 8 weeks, then you can start doing your drug testing because the hyperalgesia is stabilized, and you can see sort of clearly what's going on. But it's a lot of training. It's a 4-step process. It's a great model. I've trained a couple other universities on it. And I think that it's a chronic pain model. It takes a lot of time, and so people get discouraged. But I think the evidence, that it provides is very important. So it's, but I mean, I'd love for you to watch and see it. It's a very interesting process, but it's a lot of training, and but it provides really good data. So.
Thank you. Anybody, go ahead. It's okay. We will.
I just did it. Thank you.
Dr. McAllister. I'm very fascinated with the lecture. Actually, just fascinating even to think of applying mechanistic models and trying to treat pain pathways, which we have not actually ever thought of, as far as I know from literature. Saying that, I just wanted to ask you, since you're a neuroscience background, do you think nociceptor sensitized pathways can be reversed ever? I mean, I know that knowing about opioids and narcotics, certain pathways form and they become more and more hyperalgesic and less responsive to pain management. Those people never revert back. There are things in the future which might reverse this pathway.
Well, thinking about nociceptive sensitization, especially in the periphery when you're talking.
Stacy, speak in the microphone.
So when we're talking about nociceptive sensitization and in the periphery, particularly the sensory and sympathetic innervation within the cyst, we have used particularly cannabinoids, different cannabinoids that have almost shrinked the sensory and sympathetic nerves, so it is decreasing the algorithmic input to generate pain. So I think there are ways to do that. I have not looked at oxidative stress and aldehydes relative yet to the innervation, but for me, because it's sort of, and I want to say Tulandi, I can't remember. Many clinicians have observed that more pain is associated with increased innervation. And so there's different forms of evidence that support, in my personal opinion, is the pain is definitely related to the increased sensory innervation that develops with endometriosis in the endometriotic tissues. So I think there is a way to decrease the pain through the innervation. I don't know the exact way to do that. I know that we've done some cannabinoid work and we had some hard time getting additional funding to continue that. But I can tell you that using cannabinoids, that we have seen an amazing change in innervation, a decrease, and a quick one, like within a couple of days. It's crazy. So I would like to look into that further. But relative to this and oxidative stress, I have not yet looked at the innervation. I'm not sure if that answers your question.
It does, thank you.
I'd be happy, I'd love to talk about it more with you.
Thank you.
There is another question in the back, please, and then we can go for lunch.
Hi, Stacy, I really enjoy your talk.
Winston.
Are there current drugs that will target the aldehyde dehydrogenase 2 pathway?
Yes.
And the last part, would you consider translating your work to also primates, non-human primates? I know that some non-human primates, my investigation at Emory, that they have primates that spontaneously develop endometriosis. That would be a nice preclinical model in terms of translation.
And they do have a mouse now, a spiny mouse model that actually menstruates. And so I've sort of been trying to, make that connection and collaborate because it'd be interesting to do that as well. But, primates, they do have spontaneous, spontaneous, they bleed monthly. I think that that's difficult because, from my experience, it's very hard to get funding to support, primate studies. But I think it's important. Did you do that at one time with ACTOR, with your grant, that endometriosis grant you had, where you worked with primates? Because if that's possible, I would love to, proceed with that because reviewers do always ask. But I find it's just so expensive and it's so ethically regulated. It's really hard to get funding for primate research.
No, we didn't do that with Actor, but just in a recent conversation with one of your colleagues at Emory, he said that they see that all the time. We could provide a specimen as well.
I think that's important.
Thank you. You have a question? No? Yes, microphone please to her.
Thank you. It's very interesting to me because I've been looking into endometriosis just as a patient advocate and the research behind it. And I know the biological differences between the native endometrium and actual endometriosis tissue is very distinct and different. So how is that going to be representative across future studies and research using these kind of models? And how could that have an impact on what we're, shifting towards patient and human representations?
Well, I think it's important, so with the human data, we collected these samples, they're patient maps, ectopic and ectopic, and we found that they're both decrease in ALDHT and the increase in H&E. But so when you're looking at a rat or a mouse model, it's a little different because, if that if the decreased ALDH2 or whatever was active before, you're not going to be able to find that in a mouse or a rat because you are depending on the model, you're injecting, uterine tissue from a separate animal, or, the disease is not actually occurring as it is in women.
So how can we say that the naturally occurring disease and the surgically stimulated disease is going to produce the same outcome?
We cannot say that.
Okay.
We can definitely not say that. I mean, and so I do think it's important if we can get that spiny mouse that, naturally menstruates, because it's a lot.
to the microphone.
Sorry. So it's a lot less manipulation and more clinically relevant. But the primates really are the way to go, in my opinion, if you can get it funded.
The naturally developing process.
Yes. And I feel like right now we're doing the best we can with what we have, but it's an excellent question because it's not, rodents are not humans, that's a great question.
All right, well, thank you very much. I appreciate it. We have more interesting talks coming up after lunch, so we on the same line of science. So go ahead for your lunch and learn, and we will be back.